make the slide. Maybe it has not reached here. I sent it only late night at about 10 p.m. Sorry for that. Because we were supposed to have a slide with a particular backdrop. Nevertheless, in this keynote lecture, I just thought that the theme of this conference that has been put forth in the RADCON is so nice, breaking the clinical barriers. And I thought, let me just speak on that, on some work that I did way back, almost about 15 years ago, and how was the journey to break those barriers. So I'm going to do that, and the slides will also give you a nostalgic feel without any AI effects, without any designs, etc., the way the PowerPoints used to be at that time. This is just to tell these are the early steps, and many of us who would want to step into breaking the clinical barriers today would face similar situations. So I thought I would like to share the first-hand experience that we had where we did succeed in breaking clinical barriers. And that too in the field of diagnostic radiology. So the radiologist as a clinical navigator setting up a diagnostic radiology clinic, what has been our experience? So I have also chosen the slides which were presented by one of my residents when we made the first presentation in our own hospital, that what has been our initial experience after setting up a radiology clinic in that hospital. So what were the problems that we faced and even face today time and again? I'm sure these things are not unfamiliar even today. No clinical notes. A small chit of paper from a treating doctor, even today, something scribbled, and then it says, do an MRI. I mean, you have no idea beyond what it is. So even back then, we realized the problem of no clinical notes. We all who do radiology, we know that an image speaks, but it speaks in shades of gray. To fill in color and to come out with the final diagnosis, we need a lot of inputs. In radiology itself, we need what has been the earlier imaging that has been done. What was the impression on the earlier imaging? Earlier imaging, how has the change evolved? What are the clinical inputs? What is the treating team thinking about? And all this makes a world of difference in our own output as a radiologist. But what do we get? Is just a requisition which states that we want this test. And things have improved, but still not changed to the desired extent that we want. So this slide certainly gives me a lot of nostalgia, and I'm sure most of us can correlate with it. Even on ultrasound, CT and MR, okay, we can accept X-rays, radiographs. There are no clinical notes, let's say. Because most of the places, because of extreme shortage of radiologists, plain radiographs are not reported by radiologists. Wherever there are residents, certain radiographs may be reported. There are few hospitals where 100% of radiographs are reported. Few and rare. But what about ultrasound? What about CT and MR? A CT where we are going to give radiation. CT where we are going to give a potentially death-causing medicine, that is the contrast, which can cause an anaphylactic reaction. It's a reality. Even there, we don't have clinical notes, and invariably it is written as CECT. Often, the term used for a radiograph is something which our technicians are not used to. Radiograph, lower abdomen, I mean, he knows pelvis, he knows abdomen, he knows KUB, he knows spine, but lower abdomen, but then this is what is reality. This happens. The part to be radiographed, something like shoulder. For us, if you ask, we'll say, okay, our AP le lo. Take an AP radiograph. But for a radiography technician who knows so many views of the shoulder, he really doesn't know what exactly has to be done. And he does not even have an authority, by and large, to change things. Okay, if somebody wants to take further clarifications, Often there is no signature of a doctor. Often there is no name. Often there is no rubber stamp. Often if there is a rubber stamp, it is so faint you can hardly read. Often the rubber stamp is so phased out, worn off, that even that doctor may not be able to read what are those alphabets. But then it's going on. Similarly, it may sound very simple to us, but what particular radiography view has to be taken is not known to most of the doctors, most of the specialists who are not from that field. And there are times when in the hurry, the body part is written wrongly or the side is written wrongly. And the technician has no choice but to do that. And he may still get the ire of the referring doctor. Hey, तुम देखा नहीं वो पेशेंट जो है लिम्प कर रहा था, नी में पेन था, तुमने कहाँ एंकल कर दिया? राइट साइड से लिम्प कर रहा है, आपने लेफ्ट साइड क्यों कर दिया? Not realizing that the doctor himself has written the wrong side. And the technician may not know, because often a radiograph of the opposite side is done only to compare. But the radiographer is at the receiving end. Even urgent cases, we may think that at least an urgent case will have some clinical notes, some indication why it is required. But oftentimes that is not there. So these are all 2012 that I am showing you. This again is a very common problem even today. Advised Doppler, both limbs, arterial and venous, full stop. And it is also very surprising that at times it comes from the Department of Vascular Surgery. We can imagine a situation, maybe 1 in 100, where it is difficult to make out whether it's an arterial or a venous. But then oftentimes it just comes arterial, venous and both limbs. Latest, it happened that it was written, patient of varicose veins, Doppler, arterial, venous, upper limb. This has happened very recently where I practice. And when I rang up, the vascular surgeon said, "Oh, I'm so sorry." So what I want to say, mistakes can occur. And they do occur. Now, more often than not, when an investigation reaches the radiology department, the investigation is seen either by an assistant, who is not even a radiology technician, at best by a radiology technician. And what happens if there is no clinical note? Because we tell our technicians, you will not do an X-ray if there is no technical note. You will not do an X-ray if the proper view on the side is not mentioned. So what happens? The patient from the reception has to go back all the way to the OPD, and the OPD may not be the same day. So, having faced these problems and realizing that many a time the radiology department is scolded, scorned, abused for mistakes that are not theirs. So what is the way out? So we thought, we did some brainstorming. So let me tell you the ground check. So this experiment for the first time was done in a 600-bedded hospital. It's a multi-speciality referral hospital. It's of the armed forces, very well disciplined. So if I have picked and chosen these, that is not that these are 100%, these are exceptions that have been picked up, but that's happening. So if it can happen in a hospital like this, it can happen anywhere and everywhere. The workload of a radiology department, to be very, very modest, is at least twice of what actually it can handle. And that has not changed. There are few consultant radiologists. That time there were few residents. Today, at least in India, the number of residents that a radiology department has are so many that at times, in places where there are 45 seats in a year, a resident may meet the head of the department, and the head of the department may say, "Oh, I didn't know you're from my department." But back then, and even true today, in many hospitals, the residents are not so many, except for government hospitals. At that time, there was no hospital management system. There was no PACS. So life was even tougher. However, having said that, Despite there being a hospital management system and a PACS, the problems that are enumerated still remain of no clinical notes, inappropriate clinical notes, wrong side, wrong part of the body. These things still happen even today, though we have HMS and online. The only difference is, instead of a piece of paper that comes to the department, today the assistant or the person who's giving an appointment opens the computer and sees over there. So as we all know, there's a lot of variety of work that is done in radiology department, right from X-rays, ultrasound, special investigations, CTMR, and also interventional radiology, which is really seeing the light of the day and is really blooming wherever we can offer this facility. So, what happens? A patient reports to the radiology reception. Reception has appointment registers or slots on the computer. The appointment registers or the slots are modality-wise. If a CT scan is advised, the CT scan page will be opened or a register will be opened, and then you see when is the next slot. And the appointment which is given by a technician or even an assistant in certain places, because technicians are also a rare commodity. Like I was just speaking to somebody from Sri Lanka yesterday. Their appointment for MRI is about 10 months. And when I asked how about making the MRI 2 shifts or 3 shifts, they said the rate limiting factor is a non-availability of the technicians who can handle the MRI. And the appointment is given not by a radiologist, but by a radiographer or an assistant. What was the average waiting time then? The X-rays, of course, were done on the same day, but those days, or if a preparation is required, of course, then the patient will be told to take a tablet of Dulcolax and come after 2 days, empty stomach, light meal, etc. Ultrasound was about 2 to 3 weeks. Special investigations were 3 to 5 days. CT scan was 1 to 3 days. MRI was 1 to 2 weeks. So though an ultrasound may be the safest, cheapest for a government or a hospital which gives free treatment to their patients, though that would be the best way to go ahead both financially, also for the patient, but the waiting time was 2 to 3 weeks, whereas for a CT scan it is 1 to 3 days. So you can imagine what happens that a patient would undergo a CT and even an MRI and would be doing an ultrasound even later. And all this is in silos. Almost 1/4 of the patients, I'm being really modest, require multiple radiological investigations. What is the situation on the other side? Okay, we are well aware about the radiology issues. What about the other side? Situation is not different. Their OPDs are teeming with patients. Patients who are not getting well, patients who are too demanding, requests for patients to be seen earlier, requests from the administrative authorities, requests from friends, requests from relatives. So what happens? The doctor over there also, instead of going in a logical manner, says, "Acha, pain abdomen hai, can be a urethric advised X-ray, ultrasound and CT. All at one go." And back then in 2012, an IVP would also figure in. So all the investigations have been advised at one go in the OPD because he has to reduce the number of visits and the number of patients that he's seeing. So what happens? The same patient, because the waiting period is different, has to come on multiple occasions to the same department to get this set of investigations which have to be done. So this, as I said, that an X-ray would be done and an ultrasound for a renal colic would be done much later. And it is possible that the X-ray would have already given the diagnosis. But then the patient has already been advised those tests. And you try telling a patient that, look, this is not required, it is very difficult to convince that patient, even if we try to. But that situation will only come when a patient sees a radiologist. If a patient is not seeing the radiologist, the patient will undergo all these tests, and though the diagnosis has been made on day 1 on the X-ray, the patient will see the urologist or a surgeon or whomsoever had gone only after the entire battery of tests had got over. Also, in those days when bariums were common, today it is far and few, we all know that the barium can stay in the colon for up to 3 weeks. And barium clumps, as the time goes, they become really dense and they cause streak artifacts. And they could hide a small, subtle finding. So what happens? In those days, we would send back the patient, either after a scanogram or worse, after a scan has been done, because there is some doubt that we have and there are a lot of artifacts. So what all is happening because of this? There's a delay in treatment, wrong diagnosis, increased radiation, increased patient expenditure, loss to the nation too. Worst, avoidable delay for other patients who are waiting for appointments. And of course the climate change, the number of films that we give with CT and MR even today in most of the centers. So is there any solution? So maybe there is a solution. So we thought about this, we did a brainstorming, and we realized that we need a radiologist or a resident at least to see a patient before any investigation is done. And that is why we require a radiologist, or we require a radiology clinic where a patient can be seen. Even today in most of the hospitals, radiologists don't have a chamber. They are just told that you are doing ultrasounds, you go to the ultrasound room and pack up. Car to the ultrasound room, maybe at the place where the results are being finalized and uploaded, he just cross-checks that everything is fine. He has no place to sit. Where does he see the patient? So we need a place. And where is the radiologist to be spared for a radiology clinic when we already have so many investigations to be done? So what did we do? There was one X-ray room which was converted into a store, because an X-ray, at one time we had more X-rays, now we realized with modern technology we don't need that many X-rays. A big X-ray room was only store, furniture, old equipment, everything. We removed most of them to the salvage, shifted all of them into other big rooms and put a curtain. Now the store has shifted to other X-ray rooms, but nobody can see that there is a store. And from that store, we made this clinic in 2012. So what you're seeing here are the residents. Patients would be waiting here. They would come here, go get an X-ray done, and this is the faculty who would come every half an hour to 45 minutes and countersign the reports. Otherwise, what would happen? X-rays are done in the morning, resident reports in the evening, the faculty sees the next day, and the patient is called on the third day. We all who have sitting here have done MDs maybe 10, 15, 20 years back. An X-ray report was available only on the third day. But this can change the scene. So what happened? We started, every patient who would enter the radiology department would first go to the resident, whether it is an X-ray, ultrasound, or a CT scan. The resident would see whether the name, starting from the name is written, it is appropriate and things like this. Whatever is not there, he would fill up then and there. If he wants the clinical note to be expanded, he would expand then and there. Only then the patient would go to get an appointment, whether it is for an X-ray, ultrasound, or a CT scan. Those days, we did not have PACS. We still had the wet processing also. So a patient would go, get an X-ray done. The technician was told that you see whether it is adequate or not. If it is adequate, you hand over the wet film to the patient. The patient will come back to the resident with the wet film. The resident sees that the film is okay. Only then the patient was told, okay, now you can go. Otherwise, what happens? We see the radiograph, motion blur, advise repeat. Patient comes on the third day to take the X-ray and now is told, you have to repeat it. Second time again, the patient, same situation, because an elderly patient, asthmatic patient. This just goes on till somebody puts a stop to it. So this simple thing of a patient coming with the wet film, it was very disruptive, very novel, but the patient would be standing with a wet film with that hanger and the resident would say, yes, it's fine. Once we realized that this has started working well, a thought came to our mind that we are seeing that yes, the CT scan is indicated, but somebody else is doing the CT scan. I'm not posted to a CT scan. That is where we started the unit system. Exactly what happens in medicine, surgery, gynae, pediatrics. So we divided the department into a consultant and residents from third year, second year, first year. They're all in the same team. They sit in the OPD on day one and then do the CT and MRI on the next day and the ultrasounds on the third day. Why this? Because CT and MR, invariably the reports would get spilled over to the next day. In the ultrasound, you're free in the evenings, you could catch up. Something left, you can still catch up on the X-ray day. So this is how we stepped into the unit system. What are the problems we faced? Now the problems started coming up from our referring doctors. You can very well imagine. For the shortage of time, I'm not going to read each of these slides. So the questions were, oh, so you are doing the clinician's part, huh? You think radiologists are better than clinicians? So then why don't you treat the patients? Take the clinical responsibility. Hey, look after wards and ICU also, man. Worst, how can you do a test when it is not required by a treating surgeon? I'm sure these kind of questions, anybody who has tried to argue, because invariably it leads to an argument with a doctor who's referring, would have faced these. So I drafted answers for my residents. I said, you are going to give these answers. In short, the answers are, sir, I am an MBBS doctor first. I have been the topper of my batch. The best of my batch have joined radiology, not your subject. So we know the clinical aspect better than your residents. We see patients from all the specialties, sir. We have an idea of what other conditions can mimic your field diseases. So allow us a free hand. And I had given this liberty to the residents. You will answer it to this extent. I am there to handle it. The radiology clinic moved on. And now you can imagine, with the radiology clinic and the unit system, it's a dream, I'm telling you. A patient referred to radiology. We see whether the test is indicated, not indicated, change it. Do it on your own day. And for the follow-up, the patient comes to the same team of radiologists. It increases the learning for the residents. It increases learning for us. Otherwise, we have no idea of follow-up. So it's a win-win situation. And what's the difference? Initially, in a radiology department, a form used to come. And for a radiology department which does not have a radiology clinic, there is no patient. There is a form. And it's the form which undergoes whatever is written. And the form with those images goes back to the treating doctor. The moment you start a radiology clinic and have a unit system, you switch over from a investigation form or a PACS request to a human being who's sitting in front of you. We change over from an investigation to an evaluation. And the most thrilling day for me was, I'm getting goosebumps remembering that day. One of the specialists referred the patient to Dr. Sahni for radiological evaluation. I have this patient with this problem, you give me the answer. And that day onwards, in our investigation form, an additional column came. Investigation advised, X-ray, ultrasound, CT or MRI. Lower down it was radiological evaluation. That means you don't worry what you want, what should be done. You just send the patient to us. We will evaluate and give you the answer. With this, I end my talk over here, encouraging you to say to your departments and your administrators that we too are clinicians, and MCI says that, Medical Council of India, radiology is a clinical subject. Today, many departments have started putting the name clinical radiology. What is most interesting is that NABH, world over, as you're all aware, there are entry level, and then as you go up to the excellence level of NABH, the difference in radiology comes up over here. Has the pre-assessment of the investigation done by a radiologist. We still have to win a battle. Here, the hospital has been told that you have a system, you have to have a system if you want excellence in NABH, that the radiological investigations have to be pre-assessed. This is for CT and MRI especially. It can be extended to X-rays, but there is still one battle to be won. It says, in consultation with the referring doctor. I am sure, my dear friends, the day we start doing all this, that part will also go away from NABH, and it will only remain that pre-assessment to be done by the radiologist. Radiologist takes a call whether X-ray, CT, MRI or an ultrasound or a procedure is what is required to be done. Thank you.